Hey guys, welcome back to the Foam Frat podcast. Tyler and Sam here. This week we're talking to Michael Lauria, Dr. Michael Lauria from New Mexico. He works down there in Albuquerque. He works as a flight physician. He's going through his residency. I think he's probably done now. He had like 4 days left in the interview when we talked to him. And we're talking about pre-hospital application of art lines, like not just transporting them, but actually putting them in. And so, Sam, you just had a chance to watch the interview with Mike and I. What'd you think?
I loved it. There's a bunch of topical points in there. I'll save most of them for the podcast because I think you guys cover them really well. But yeah, so I watched the podcast and then I read his blog post in drafts. I thought that was really cool too. Definitely got to check out the show notes that go along with the podcast. But it made me think of two things. So I have one observation and I have one question for you before we jump into the podcast. So one observation. You guys talked a lot about hypotension, but I'm curious for you. I'm going to tell you about a quick case here in a second. Have you ever had somebody who's really hypertensive where the non-invasive blood pressure cuff was garbage? It just wasn't reading right?
I have not. I've had it where I am trying to take a manual blood pressure like by listening and I don't go high enough, and so I miss like a really high systolic. But as far as like the actual machine, I can't say I have, but I could have and just not known it because that's all I'm using is the blood pressure
Sure.
cuff on the machine. So I have not experienced that. Mine have always been lows, but I'm sure it can happen.
Yeah, so I have one case. So in the refresher, I teach this class on arterial lines, and it's like for all levels. It goes over like the initial setup. Like how you set up the pressure bag, get the air out of there. All the lines, how you zero, and like all this kind of stuff. And then we just go over some square wave testing. What if it's underdamped, over like all that kind of stuff. But I start them off with a case that was a very unique case that I encountered, and it was for a patient who we went in. We were called in for a patient who was septic and on BiPAP and pressors, and that's all we knew about the patient. They're at a very small outlining ICU, and we came in, and this patient, sure enough, is on pressors. I mean, they were on like 30 of levo. They were maxed out on phenylephrine, and they had just hung vasopressin as well. And so I was like, whoa, like, and this patient isn't even intubated, and so they're on this BiPAP. And I'm like trying to get to the bottom, like what's going on with this patient. I immediately thought like, man, they must have like a bad lung infection or something. Like, no, they came in like 4 days ago with a UTI and their blood pressure has just been going down and down and down and down and down. I look at the oscillometric blood pressure cuff on the wall, and it says that their systolic is like 80. And I'm like, man, like, are these infusions going into the floor? Like, is it not even connected to the patient? Like, what's wrong with them? Do they need calcium? Like, this is a definite stop point in this resuscitation. Like, why is their blood pressure that? And they're awake, but they're like encephalopathic. Like, they're acting really weird. And you can hear that the patient has a bunch of wet lung sounds. And so I'm like, did this patient like puke in their BiPAP and aspirates and nobody noticed? Is this pulmonary edema because they have ARDS now? Just a very confusing clinical picture as we walked in. And so because of they didn't have an art line. And so because of all the pressors, it's one of the first things that we asked for when we walked in was an art line. And to make this story short, when that art line went in,
Too
that
late.
blood
No, I'm
pressure
just
ended
kidding.
the blood pressure ended up being like almost 300 systolic over like 150 diastolic. Unfortunate for the patient. So that was a misstep. So that part is kind of like, yeah, that's crazy. But the unfortunate part for the patient is that we never transported them after they realized that this patient's blood pressure was that high. This was cardiogenic pulmonary edema from high afterload.
Mhm.
And the patient actually, the reason that they were encephalopathic was because they had multiple brain bleeds.
Holy crap, dude.
And so they ended up taking that patient and putting them on comfort care. The transport never
What
ended up happening.
facility was this? No, I'm just kidding.
Oh, this is just a made up story. I've never seen a patient like this before in any service area that I've responded to. But no, that's a crazy case, right? So like I was
Yeah.
reading some literature on that, on how like, pressors can make your non-invasive blood pressure cuff like pretty inaccurate. And the spreads that I was seeing, there are all these different things, and Mike will bring it up in the blog, but like if they're over 100 systolic or 180 systolic, like it can start to get really dicey, and the spreads can get really wide. This patient must have had some kind of comorbidities, like maybe they were diabetic, or maybe they had some arteriosclerosis, or something bad happened along the way. But I just thought it was worth bringing up. Like, that's a really crazy case. And it's not always like the low ones that are inaccurate. Sometimes it's the crazy high ones too. And your pressors are working so crazy that you don't know. What happened to that patient was the higher the pressors went, the lower the blood pressure read. And so you get in this never ending circle.
Yeah, I thought you were going to tell me that the art line was actually placed in a vein, because I
Ah,
remember an episode on MCRIT where he talks about like stop points in resuscitation and how they're doing everything they can to get a blood pressure to come up. And it turned out like the art line was actually in a vein and they had been in a low flow state and they confused. And you probably heard Mike and I talk about when you're in a low flow state or cardiac arrest, like sometimes that can be confusing. You have to really know your anatomy with where you're going because you can't really count on the pressure and the sometimes not even the color of it to know that you're in an artery. So I think that this is a great tool. I think it's something that we need to consider, especially in the critical care transport realm. I don't know if this is ready for prime time 911. I don't see people starting art lines in the ditch on a trauma patient. I don't think that's where we want this. There's a very specific type of patient, and Mike does a great job of painting
yeah.
exactly who that patient is. So
I do
let's
have
get
I
right
have
to it.
one other logistical question about checking
After this
blood
question,
pressures.
then we'll get to it.
I just have one more question. Do you ever try to check a blood pressure almost like you do on an LVAD patient? So like take a manual cuff, pump it up, and then wait for the artery to expand on ultrasound? Because you know you can do that with an LVAD patient.
Yeah.
Cuff up to 120. You put ultrasound on brachial artery. The first expansion is the map. Can you do that with these patients? Like, let's say your oscillometric is like just useless at the moment. You don't have an art line. Is that an in between step at all? Can you ultrasound the brachial artery, wait for an expansion or pulsation, and match that up with the systolic? Is that a thing? It's almost like a blood pressure over palp, but with ultrasound.
Yeah, no, you totally can do it. Um, it's just I think sometimes the logistical steps of taking it out and doing it, but I think that could be an option for sure. You're watching a couple things, you're watching the number and then you're trying to watch to see when you start having that pressure overcome the pressure of the cuff. So I
Yeah,
definitely know you can do it. It's been validated in like LVADs, like you said, but
yeah,
I've never really seen anything looking at that in the patient that has like a septic shock on a bunch of pressors.
yeah. I was just wondering if that could be like an in between. I was kind of like brainstorming, like because you were painting that like a very panicky situation in the helicopter. Where it's like can't hear crap, so you're not auscultating anything. You can't, you don't immediately have access to an art line, and your oscillometric blood pressure cuff is not working. You're like, what is the status of this patient right now? Like, what is going on with this blood pressure? It's kind of a panicky situation. You're like, should I adjust something or should I not? Like, we need to find a way to get a reading. And so in my head, I was brainstorming, like, I know you can do that with LVAD patients and just watch that expansion, but I was thinking maybe you could almost get like a pseudo POCUS, like blood pressure over palp type deal, and it wouldn't be like you wouldn't have to rely on sound, and you wouldn't have to rely on like tactical feel of a pulse, which can also be very difficult in patients with a lot of pressors on board. So I thought that maybe, I don't know, you'll have to let me know if you try it. I thought that maybe that could be an in between step to at least try to figure out maybe what a systolic is.
Yeah, there was the Andromeda study where they looked at titrating pressors to a MAP or to capillary refill. You remember that study?
Mhm.
And they
Yeah.
found that cap refill was a better indicator of perfusion. But it's interesting because that's in a hospital setting, and like
Mhm.
when you're outside or you're in a helicopter or you're transitioning in the transport realm, I just feel like you're prone to the environmental temperatures. And I don't know how reliable that would be in the pre-hospital intra-facility transport environment. So yeah, maybe that would be a good step. I don't know. That's interesting, but I think it would be ideal to just have an art line in.
Oh yeah, yeah, without a doubt. I just we'll have to look into that. Maybe that'll be a question for another time. But yeah, awesome podcast with you and Dr. Lauria. Great guy, and yeah, let's cut to it.
Now we're going to talk about arterial line placement. And Mike approached me, I don't know, it was probably a month or so ago. And he said, let's talk about the application of arterial line placement in the pre hospital environment. And something I think we've all thought about. And we've been like, God, it would be really nice if we could just have an art line. But what is the feasibility of it? And so he wrote a really nice blog, and that's going to be the show notes for this episode, and you guys can check that out. But what I thought we could do is address the questions that pop up when I said, hey, I'm going to be talking to Mike about arterial line placement. And you could see just this flood of questions, and they all really centered around why should we do it? And then when should we do it? And it seemed like the people asking why were not the people who were routinely transporting patients in this environment. And you, being a flight physician and also a previous flight paramedic, and I'm sure you probably still have your paramedic license, you had a unique perspective on this because you went from flying these patients maybe without an arterial line, or maybe you did place them at DART, I can't remember, to now being able to place them in the hospital environment. And you make a really strong argument for the why, but let's unpack that a little bit and talk about why should we even consider taking the time to put an arterial line in and monitor an invasive blood pressure versus just the non-invasive.
Yeah, so those are really great questions. And before I answer those questions, I did want to give a shout out because the issue was primarily raised actually by one of our junior flight physicians who's going to critical care fellowship, Mike Wasserman, and another friend of mine, another ex-PJ. His name is Colin Sandiford, who's actually a critical care, does ground critical care here in Albuquerque as well. And we sort of were having this discussion and realized, well, we had done it at DART, and I used to do it at DART, granted infrequently. And now, as a flight physician, I do a little bit more because I'm more comfortable with it. But we're like, why aren't we doing this more often in transport, especially considering the fact that we can draw EBGs, no problem. We let nurses and paramedics do it all the time, but not placing lines. So the question of why is actually very important. And I think one of the first things we need to delineate is the difference between the traditional, Society for Critical Care Medicine guidelines for when you place an arterial line and contextualizing that within the scope of transport. Because it's a little bit different, right? We're trying to take people from outside hospitals or sending facilities to receiving facilities. And we don't want to stay there for half hour, 45 minutes working on some very painful, small, calcified artery trying to get an arterial line in, right? So we have to take that into consideration. So understanding that context, I think that the reasons, the primary reasons for placing arterial line is that there is sustained hypotension or hypertension that's causing a problem, right? So not like some liver failure patient who's like slightly hypotensive and has been living that way since, the Reagan administration. And, some or some person who lives with a blood pressure of 180/90 and they're totally fine getting transported for like toe cellulitis or something like that from some small outside hospital in the middle of nowhere that has no specialty care. So that's important. It's got to be way out of whack, and it's got to be causing a problem. And I would say secondarily, you need it to very carefully monitor or titrate things that you're doing for the patient. So when there's good evidence that suggests a patient should have their blood pressure controlled below this, or they're profoundly hypotensive, it's causing a problem, and you're trying to get it up with fluids, pressors, additional drips, stress dose steroids, whatever you're using as part of your algorithm for a septic patient, let's just say, then it would be reasonable at that point as well. I think that practically speaking, what do I do at the bedside and what would I expect our teams to do at the bedside? I would ask them, is there a problem? Is it or something out of range, so the hypotension or hypertension? Is it causing a problem that needs to be addressed? And the next question is it sufficient to go with the non-invasive blood pressure cuff? And to answer that question, I look at it and I say, is it reasonable? Is it basically precise and accurate? So if that person is like, we tried several different blood pressure cuffs on them and their blood pressure is consistently, 190 to 200 over something, and then you're doing things to bring the blood pressure down and very consistently you see the blood pressure coming down on the cuff, then I would say it's probably reasonable to just go with the cuff. because at that point, if the blood pressure is responding appropriately and it's continually precise, there's precision in the measurements, they're pretty close together, then that's probably reasonable. If, however, there's a problem, or there is an aberrant, a problem with their blood pressures, and it's too high or too low, it's causing major issues, right? And that blood pressure cuff is neither precise nor accurate. So it's giving you like the 200 over 190, or like the worst, like dash, 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 dash. It like can't read a blood pressure. You probably need to address that. The next question, the fourth and final question um, is this something I need to do now? Is it something that I can do en route, or is it something that needs to be done at all? So, for example, if you have a patient who has like an aortic dissection at some small outlying hospital, you should not, under any circumstance, stay there at the bedside trying to place an arterial line. If that person needs definitive surgical management, our job is to resuscitate them and manage them as we get them to that definitive care. Often that, and it can be done. So I was primarily flying in the EC 135 at DART. In that case, if you're in the EMS seat, you can flop their left wrist into your lap as you're flying, and you can dump an A-line in their left wrist, no problem. In other aircraft, fixed-wing aircraft, for example, same thing. If they're sitting up against one side of the aircraft, you can sit across from them, pull their right arm in that case into your lap, and you can start the A-line. But under no circumstances in those cases should we be waiting or delaying care to do something like this. Other examples as well might be a trauma patient. So if you land on the side of the highway and you have someone with profound traumatic injuries, head injury, chest injury, like free fluid in their abdomen or bleeding into their belly, and they're hypotensive, do not start an A-line. Certainly do not start one on scene. That person needs blood. They need active resuscitation. They need to have their whatever's causing their hypotension reversed immediately as soon as possible. And you don't need an arterial line to tell you that. If you have some ridiculously long transport, like a 45-minute flight or a 50-minute flight someplace, and everything else is done, you've given them all the blood, TXA, everything else, and you're still concerned about the hypotension, you want to try it in flight, sure, go for it. But again, another case where we should never, ever, ever delay transport for doing something like this.
Yeah, excellent points. And I think that the patient population we're talking about is such an important aspect of it, because some of the questions that were asked were, okay, you have and I think it was a guy named Jeff Poland said, surgical versus medical, and when I think of an art line that I really want, my head goes to like that septic patient who's on multiple pressors and my blood pressures are all over the place. And I'm thinking, all right, there's really no rush. There's no rush to get out of here right now. We're giving antibiotics. They're going to this hospital for whatever XYZ reason. Let's take some time and let's do this so we can properly manage it. Because as well as I do, as soon as you get in that helicopter and you got limited space, you can't hear anything, stress factors go up a little bit, and then you can't get a blood pressure, that can consume your entire flight going, okay, I think I feel a pulse, and you're no longer making those decisions based off of a number anymore, and you're trying to look at the patient, and then they're intubated, and you can't really use mental status. And I think it makes it makes sense to take the time to just start it right there. But is there a certain length of transport where you would say, nah, it's a 15, 20-minute transport, let's just get them there? Do you think that there's a time caliber that we say, hey, if it's over this amount of time and it's not a surgical emergency, let's take the time to do it? Or would you say, if you like you mentioned, if you're just having a problem getting a blood pressure and it's not a time emergency, just go ahead and do it regardless of the transport time?
Yes, that is a great and very practical question, and it gets into a little bit of gray area. My comments on that are generally, first of all, I think you're absolutely 100% correct. If it's not a time-sensitive pathology, STEMI, stroke, they're not septic because like they have a surgical abdomen, right there. They don't have a ruptured viscus. They don't have something like that requires emergent surgical intervention, then yeah, I agree with you. If you can't get an accurate blood pressure, or it says, like I said, 180 over 170, and then 40 over 30, and then dash dash, and then something else, and you have no idea what their blood pressure is it good for the patient for a period of time to have no idea what you're doing? You're basically titrating to, you have no idea at that point. You could say mental status, but again, if they're intubated, that's not going to be the case. You could say pulses, but we know that the time honored tradition of whatever it is, like 80 on a radial, 70 on a femoral, and 60 on a carotid, it does not correlate with actual blood pressure. So really, pulses is not a thing. Then it's very reasonable. The thing that I think I made a mistake on for a long time in transport, I say it's a 15-minute flight, right? It's a 15-minute flight. But in reality, right, by the time you get the patient packaged and onto your air cot or stretcher, and then out to the aircraft and loaded in an aircraft, and then you do, all your pre-takeoffs and your checklist, and then you fly the 15, 20 minutes, then you are unloading them and getting them out of the aircraft and getting them into the hospital and taking them down the elevator and then into the ICU. And then, right, it's not just like Alakazam, Harry Potter magic, like 5 people show up and immediately line the person, right? Often you have to get them transferred over in the ICU, and then one of the residents in an academic center will come and see them, or the receiving attending will come and see them. And we're often busy, so it's not like, sometimes it'll happen immediately, but sometimes it won't happen immediately. Well, they won't get the invasive blood pressure monitoring, although usually I think that's recognized pretty quickly, and we'll place one. So that we had to be careful when we say it's a 15-minute flight. It's a 10-minute flight. We should just get going, because it's not about the flight time. It's about time that patient is profoundly hypotensive, under resuscitated or undertreated, and you just don't know it. So that is where like the art and science, like sort of the gray area blend. And you as a transport professional are going to have to say, well, it's like a 15-minute flight, but the helipad's actually outside. I got to walk into the hospital, then go across the hospital campus, through 5 buildings, up 2 elevators into the ICU, versus, what, we just have to take this person out to the helipad, get them over there, land, we'll go right downstairs. And I think that we have a safe margin in the precision of the blood pressure, where we got a couple of 65s, but it's reading between maps of 65 and 75, that I think it's reasonable, and they're responding to the pressors appropriately and the fluid and whatever else appropriately. So I think we can make it. That's hard to write into a protocol or a guideline, and I think it's something that you guys as transport professionals will just have to take as a case-by-case basis. But I hope that frames the thought process.
Yeah, I am so happy that you said that. And at one time I made a little flow algorithm, and it was like, is the intervention needed? And it was like, yes, then you should perform it. Like the whole, we're only this far away from the hospital. Now, sometimes you could probably tease some of that stuff out, but you're right. 15-minute transport is way longer than that when you look at the time you're actually monitoring the patient. I think that's a really salient point to make. My next question for you is, I've had a couple situations where I've been like, we need an art line before we leave. Like, I can't get a good blood pressure. I can't place one. And so I call in the physician. He comes in, and they go to place one. And it seems like the sicker the patient is, like I've seen some people really, really struggle to get a radial art line, and even sometimes a femoral art line. And in my head, I'm like, well, we get IVs all the time. Isn't the artery even easier to get? And it seems like that there is a certain patient population that I want to have an art line, but they're typically the ones that are the hardest to get the art line on. Have you seen that same thing, or do you think it's just a lack of familiarity with the skill in some of these outlying hospitals?
No, I think that art lines are, as it turns out, are one of the most humbling procedures, because you're right. It's like the totally freaking sick person paradox, right? Like, the sicker they are, the more you need things, often the harder they are to get, whether it's a central line or an arterial line or just a blood pressure or whatever, right? However, it is interesting because arterial lines, like I said, are pretty humbling in the sense that you'll do, I'll do 50 or 60 and no problem, easy day. And then you'll have someone who just happens to be a bad vascular path. Their blood pressure's fine. You can see the artery under ultrasound. Everything looks fine. And then you hit it and you get blood flash, no problem. And you're like, hell yeah, this sucker's going in. And then you go to thread the wire and nothing. Think. Like you just can't get it in. You cannot for the life of you get it in. You try several times and then you feel like, an idiot because you're like, oh man, like what am I doing? I thought I was pretty good at this. And then you get someone who's really good, like a vascular surgeon or someone else who has to try multiple times. And they're like, yeah, man, it was just super bad vascular path, or a vascular cardiac anesthesiologist who's used to working, who's does these all the time, like every single day, multiples every single day. And they're like, yeah, it's just really calcified and nasty and hard to get in. So it is something that, like 95% of the time, you're absolutely right. It's like a big artery, like you can see easily on an artery and nail it, no problem. And then there is a small percentage of the time where it's just going to be really hard for anybody. And it's probably not a lack of training or experience on anybody's side. It can just be really difficult, which is why
How
it's
many times
also.
are you going to try to do it before you call quits on it?
Oh, a great question. So without any evidence, so out there with a totally evidence-free zone, practice-wise, I always think of that old school Tootsie Roll Pop commercial with the owl who's like, how many
Yeah.
licks does it take to get the Tootsie Pop? He goes 1, 2, 3, and he like bites it really quick, and he's like 3. There you go. So 3 is like my magic number. I try once, I try twice. If I think about, like, am I doing something wrong? There's something I have to change. Try to change some stuff. Try a third time. If that doesn't work, it's time to get out of there. Like you can't sit there all day and keep trying. Actually, that's my policy with like a lot of procedures, as a matter of fact.
And let's say you get the first one, you actually puncture the artery and you start trying to pass your wire through and you can't get it to go through. Like you said, you keep dink, dink, hitting it and you can't get it to pass. What are you counting as an attempt? Like actually hitting the artery or trying to pass the wire? Or will you try the other hand? Like what's your kind of gestalt when it comes to that?
Yeah, so good question. A phenomenal and super smart vascular surgeon once told me that soft tissue is nothing, intima is everything. So as soon as you penetrate the vessel, you're essentially committed and you own a certain part of that procedure. If there's a complication, if something goes wrong, if they start bleeding all over the place, right? So I count any flash or any blood flow from hitting the vessel as an attempt. I would not want to, and even if it was not calcified or I was having trouble passing the wire, even if it was under any circumstance, hitting that any particular artery more than 3 times is a pretty hard stop for me, and it's either time to reconsider if we have to do this right now at all, or is it if we have to do it? Like if I was in the receiving facility ICU and we needed it, time to consider another point of access, axillary, femoral, what have you.
And now you mentioned maybe doing this in flight for a surgical emergency and how you shouldn't be wasting time at the bedside. And I 100% agree with it. And you mentioned like you're in the 135 and you just kind of grab the wrist over and you can do it right there. Which makes me wonder, like, how sterile do we really need to get? Like, is this like the, Weingart talks about the chlorhexidine, maybe a drape, and maybe a mask and stuff, but not going to the extreme extent, letting them know, hey, this is, I don't want to say dirty art line, but this is an art line that was started by us. It's probably going to get replaced. How sterile would you go in the transport environment or even at the bedside?
So great question. In general, arterial lines, for whatever reason, have a very well, actually, not for whatever reason. We have some theories about why it is, but arterial lines have a very, very low rate of infection. Very, very low. Theoretically, different people have like their different thoughts on it, and I don't think there's any evidence behind this. But theoretically, because there's not a lot of stasis in the arterial system, when blood is whizzing by at those flow rates and pressures, like the little bacteria, theoretically don't stick to them and grow. I don't know how true that is. I imagine that sure, like through the soft tissue skin tract, you could certainly start to grow something and cause an infection. That said, we should always practice as best as we can. I never use the term dirty. I'll tell the sending facility this was our ability to execute a sterile procedure was limited by the logistics of transport, especially with the central line. Less so with an arterial line. We should be doing it as best as possible. So basically what I would do is I would flop their arm into my lap, put a towel down, like a clean towel below their arms, in between my legs and their arm. And then, chlorhexidine all over the place. Let it dry for a couple seconds while you're prepping everything else, using sterile gloves if you can. And these days it's not a problem because I think we're still mostly wearing masks. Make sure you have a mask on, and do it as best as you can. In fact, we're carrying like at least a pack of sterile towels, and if I can, I'll at least put a little bit of drape over that. So I try and keep it as sterile as possible, and then just tell the sending facility. Again, this is a kind of a lot to go through, right? You have to set it up, you have to get sterile-ish, you have to make sure everything's as clean as possible, use the best sterile technique you can, and so because of that, you really gotta have a case for it's indicated. Like, we were treating this guy with an aortic dissection, and he was, we had him going on the esmolol, and then we added the nicardipine. He was still hypertensive, and this stuff was going on. Like, the blood pressure cuff was all over the place, and I didn't know how I was titrating things. So I decided in flight, in like the 20 minutes that we had in cruise flight, to go ahead and do this, and it might be worth it in that point.
In your blog or paper you wrote, you listed all the equipment that you need to do this, and then I texted you and I was like, could I just use like a 20 gauge IV catheter and just connect it up? And in my head, I was always wondering, why couldn't I just do that? And you shed some light, and you're like, well, that's kind of what we used to do until these Arrow, or whatever they're called, the new well, just explain it, because you'll do a better job than I will.
So it's a great point. And, today, it's especially in the hospital, we have like kits with lots of stuff, all sorts of extra equipment. In fact, I think we waste a lot of it. In the simplest way, all you basically need is, something to clean it off, something to stick the artery and get the catheter in, almost like an IV start kit, essentially the equivalent of the equipment that's in an IV start kit. And then, of course, the A-line setup, right? Yes, in fact, the nickname for like the little 20 gauge catheters, circa 2010-ish, was little pink ladies, right? They were basically they came in like the pink, little wrapping stuff, and there were 20 gauges, and it was the old school one, so it was not the ones with like the auto safety needle retraction, whatever. And those had a very nice flash chamber, worked really, really well, and you could do it. What makes it a little bit easier is the Seldner technique, which is used by our colleagues in cardiology, interventional cardiology, vascular surgery, anesthesiology, where if you can just poke into the artery, you may have less trouble actually floating the catheter through if you send a wire through it. So that's why most of the times, often the commercially available arterial line catheters made by, and again, I have no commercial interest in Arrow, but it's just the one that our hospital happens to use. They have a wire that goes through them. So as soon as you get flash, you actually thread the wire through the catheter, through the needle, and then the catheter goes over the needle and then over the wire into the vessel. So by having the wire in the artery, it makes it a little bit easier. It basically makes it a little bit easier, but you could absolutely do it without it. Now, the converse is, interesting enough, is true too. I've had really difficult IV sticks on like little old ladies and patients with terrible vasculature that tend to blow all the time. And I've gotten one of these little arterial lines with the pre-made wire in it. And as soon as you stick it and get a little bit of flash, instead of trying to advance the needle and thread the catheter, which is usually, I find, when you go through, or where things tend to blow, as soon as you get flash, you very delicately thread that wire into the vein and then thread the catheter over it. And it actually works quite well.
I like that a lot, because that's probably one of the most common complications of an IV. Is we're always told, all right, you get flash and then go in just a little bit more, but nobody really knows what that little bit more is. And when you start watching it on ultrasound, sometimes that little bit more is going through the back wall of the vessel. So you're saying you're putting it in, you're getting flash, know you're in the vessel. Now, instead of advancing the needle, you're advancing the wire,
Yep.
and then you're advancing the catheter over there. I love it, man. I think that makes a
Yeah.
lot of sense. I'd like to see that eventually for just starting IVs. I think that would be a great way to do that.
It's
Awesome,
not always
man.
necessary, but it's nifty and super helpful.
Yeah. Are those super expensive?
Ooh, good question. And I don't
No
know. I will
clue.
try and find out. Probably more expensive than the average IV catheter. I'm guessing.
Yeah, that probably makes sense. Well, the only other thing I wanted to talk about before we conclude this was we talked about the patients in like a surgical emergency. We talked about the medical patient, or maybe we have a little bit more time at the bedside to do it. But I do think that there could be a spot for this in cardiac arrest because there's a lot of time that we're sitting there and we're doing the epi every 10 minutes. Or if they're going to ECMO, we limit it to, 3 epis. And we have a Lucas, and then we have them on the mechanical ventilator, and then we have like the ultrasound. And so we'll do ultrasound, look at the heart. But there does seem like there's a little bit of time that we could possibly pop one of these in. And then we could actually look at that diastolic blood pressure to try
Mhm.
to target an adequate coronary perfusion pressure, whatever that might be. Do you think that this may be an indication for pre-hospital art line placement, or do you think we'd be getting into the weeds if we looked at it too much?
No, I think it's absolutely an indication, especially if that. Um, I think it is definitely an indication in the peri-arrest or cardiac arrest patient. It has, for whatever reason, not been super in vogue in the emergency medicine world. I think as when we over the years as we've gotten more involvement and we've had more critical care EM faculty and people involved, and now more and more so with advanced interventions like ECMO, it's becoming more popular, and I think more people in training are doing it specifically for this procedure. So why? The I think the Whenever you look at an indication like this, or a procedure like this, you have to be careful, right? Because there's no evidence that specifically an arterial line ever saved anybody's life or improved mortality at 30 days or 6 months or anything like that. But within the context of what we're actually doing, that doesn't always matter. Number one, and number two. If it facilitates more precise management or better care in the sense that we're doing things more in line with the evidence base, then yeah, it's probably a good idea. So, for example, if you were to, there's some literature that shows that in cardiac arrest, it actually it limits pulse checks, right? Because if you have an arterial line in there, you don't have to sit around with like one person on the carotid and one person on each radial and two people on the femoral and one person. I think I got it on the femoral. I can't feel anything on the. Oh, maybe that was it on the radial. Oh, hang on, let's wait another 10 seconds. I'm not sure. Maybe we do have a pulse. You can just look at the art line and be like, we totally lost a waveform. We were getting good
Hmm.
compressions and good pressure, and we totally lost a waveform. Number one. Number two, if we're looking at, and what I should think we should be moving to, is a more nuanced management of these patients, not necessarily having to slam them with a milligram of epinephrine every 3 to 5 minutes. But once we have people who are trained in advanced cardiac arrest management saying, all we need is a map of 45, 50, something like that to get good coronary perfusion pressure. So there's a lot of debate about where those numbers are, but you could
Right.
titrate drips and other medications, even if they were push dose, to just that instead of what we commonly see is like a map that shoots up and then it drops down. Um, so I think that there's a lot of utility there, especially in some of these patients who are very unstable and they have a high likelihood that they're going to re-arrest. It's reasonable to place it at an outside hospital for the other reasons that in transport these patients are super unstable as well, right? There's very few patients, essentially no patients, with a couple of exceptions, that are too sick to transport really, and and moving those patients can be really challenging because, like you said, you're in flight. It's 2 a.m. You can't really see anything very well. Your end tidal waveform is has always been not great because they're not getting great perfusion because they're profoundly hypotensive and in cardiogenic shock. You're titrating pressors, and then all of a sudden you start to see some ectopy. Is it perfusing? Is it not? Did we lose pulses? Did we not? And if you have that A line, it's super helpful. I also would add that I think it's feasible, especially at an outside hospital, right? Because if you show up and someone went into cardiac arrest and then like the classic, they're doing fine and they have a pulse, and then you show up and they rearrest, then you have enough people usually with the sending facility to do all the normal ACLS stuff. But then the flight crew, the critical care transport professionals, can actually do other things like, hey, ask the sending physician, do you want me to place an A line so we can, better manage this and titrate pressors, or so we can shorten our pulse check interval? And they as the sending physician are managing the whole scene. You guys can do those skills. I would, however, be add a note of caution there, which is especially if you're at a program that's doing ECPR or is involved with the ECMO team for some of these patients. Talk to them and come up with very careful guidelines and protocols about where and when you do this, because for example, for bifemoral cannulation or certain or ECPR, you do want to make sure that I would try to spare the femoral sites for the cannulation team. If you guys decide to do those, you have to have very very carefully or very good training on like ultrasound guided arterial line placement. You have to be at the right point in the vessel. You have to be above the bifurcation of the profunda in the common femoral, for example. Otherwise, they'll have to stick them again. You'll have to remove that A line. They'll have to stick them
I've
again.
seen some places too with the right radial for PCI. They want you to try to stay away from that. So, like you said, these are conversations that if you implement them, you need to figure out what your systems around you are using and what they prefer.
Exactly.
Have you figured out a good way to figure out the difference between a vein and an artery in cardiac arrest? Is there any little tips or tricks?
So really, really good question. And it can be hard, especially if there's ongoing chest compressions. This is where I think the ultrasound comes in very, very useful. Because when you can actually, the classic like anatomically guided arterial lines are fine if you have a pulse and you know what you're doing and you have a lot of training. If not, and you should always use ultrasound first if it's an option. But if not, especially in cardiac arrest, it's really hard. Basically, what you're looking at is often like two vessels that are pulsatile because you have backflow and forward flow from the chest compressions. That's when you really need to know your anatomy. When you really, really need to know your anatomy and what you're looking at in the groin. Some people say you can look at the size and shape, right? An artery shows up very differently on ultrasound than a vein will. Anatomically, you know that the artery is actually lateral to the vein. The vein is actually closer, is more medial. And once you get used to seeing them, when you're scanning up and down and looking at those structures, it gets a little bit easier because you know what you're looking at. It's also a pretty good reason, or it's also reasonable when you're looking at the radial artery. It is generally a little bit easier to see in comparison to surrounding veins in the artery, so that the anatomy is a little bit better at the radial artery and not close to any other big vessels that might look similar. If that makes sense.
Yeah, absolutely, man. Well, what else am I forgetting? Is there anything else before we close it out?
I don't know. I didn't think there was. I don't remember all of the other comments or questions that people had. Was there anything in particular that you remember that stood out?
No, I saw a lot of people that were saying you better have a damn good reason to take the time to place one. And I don't know if that would be my verbiage with it. Like, I think you do need an indication for it, but I also don't think you should be afraid to do it, especially if it's not a time sensitive emergency. To say, you need a really, really, really good reason when these are routinely placed in a lot of academic centers. And I wouldn't say they're routinely placed in outlying facilities, because honestly, they're not. You just don't see
Mhm.
it, and it's probably just unfamiliarity. But you go to an academic center and they throw them in quite a bit if they need to monitor blood pressures closely. And so, as long as you can validate the time spent, which if you looked at the studies that you mentioned in there, like, it was ridiculously fast. I was like, 5 minutes is what one of them said. I'm like, I can't even start an IV in 5 minutes. Like, that's a really fast time. And that maybe is the time from starting the procedure to the end of it. But
Yeah.
anytime you're talking about efficiency of a skill, it all comes down to how you practice and purposeful practice, and making sure you're going through the steps and the micro skills to it. And you hit on that really well in a lot of other blogs. So I think that, just like anything else, it's a skill that you have to practice. You have to become efficient with, and the most important part of doing a skill the majority of the time is just knowing when to do it. And I think you laid out an excellent foundation and some things for us to think about trying to implement this in the pre-hospital environment.
Yeah. The only other thing that I think I would add is that you just have to make sure that you go through your medical director and the staff at your facility to make sure they think it's reasonable, and come up with a good plan, very clear guidelines for when you as a team are expected to do it and when you are able to do it, when you're not, and then sort of the training and proficiency, because those are definitely important pieces of it that can't be overlooked. As nice as it is, if you can't get everybody proficient, or your sending facility or receiving facility or home facility is just not comfortable with you doing it, then unfortunately it's probably not the greatest idea. But I always tell people, I think it's interesting, um, that two things. One, kind of like you said, that people like, you better have a darn good reason for spending the time there. You got to get that patient out of here. Or on the sending facility side, they're like, you got to go get this patient out of my emergency department. Let's go. Let's go. Well, if there is no rush to get an emergent intervention at the sending facility, would you be okay if your kid, if your wife, if your husband, if your family member or best friend was profoundly hypotensive and you didn't know it for X period of time? If you're comfortable with that, you may want to consider another line of work, number one. Number two, you should be thinking very closely about that, because that's not good care, right? To leave, we would not say it's okay to leave someone profoundly hypotensive or with a map of 50 for an extended period of time. And if you don't know that that's the case, or cannot confidently say that it's reasonably improving, and you trust that blood pressure cuff, then you should probably think about at least trying to come up with a solution, and come up and do a procedure that you can absolutely do that will give you the right answer. Number two is that if you think about it, like every single day in academic centers all over this country, we have internal medicine residents, anesthesia residents, medical students, emergency medicine residents who have, like, not maybe once or twice in their entire medical school career, like, done IVs, right? Very, a handful, maybe. That's like a novel thing for a medical student. Um, and we take them in the ICU and we have them put giant catheters in, like the internal jugular and femoral veins, start arterial lines in the axilla femoral, our radial line, right? So these are people with they're super smart and they're super capable and they're my colleagues, but let's compare that to a trained, skilled critical care paramedic or critical care nurse with at least, 3 to 5 years of experience, who've done plenty of IVs, and even arterial sticks for ABGs. It is totally within the skill set to get that kind of vascular access. And in fact, I would argue that it's probably easier to train a paramedic or a nurse to do this kind of procedure than it is to the resident physicians that do it all the time. So, just some food for thought.
No, I love it, man. It's one of my biggest pet peeves is when clinicians let other people set the pace for them, and they'll say, "Oh, we didn't have time to do that." And it is, if it's a real time sensitive emergency, that's one thing. But like you said, sometimes you walk into a small facility or any facility, and they're rushing you out the door. And this could be a whole other podcast that you and I could unpack. But having the ability to say, hey, I'm recognizing what's going on and I'm setting my own pace right now, and knowing when that pace should increase and when it should decrease, and when you should do things here versus there. And in the 119 we fly, if I can, I try to start an IV in the right arm because I don't have
Mm-hmm.
access to that side. And I
Mm-hmm.
want to do it on the left. So it's just so many logistical things, dude. But dude, thanks so much for taking the time to write this out. I know people are going to get a lot out of it. I got a lot out of just talking to you about this. And even if it's not always evidence based, I just want to know like what's going on in your head, like your mental model for what this looks like. And I think that this will be a great post. And if people have other questions, maybe we can try to arrange another episode where we come in and answer those. So thanks a lot, dude. Congrats on the new
Yeah.
addition to your family and
Thanks, man.
residency. You got a lot of good stuff going on, man. We appreciate you coming on and talking with us.
No problem. Anytime.